Hello students, welcome to the exam mock series of Conceptual Psychiatry. Today we'll be demonstrating a case how you're supposed to present in your final MD exams. So I invite Dr. Milan to present the case.
Index patient, 40-year male, 10th pass, unemployed, unmarried, of middle socioeconomic strata, belonging to a Hindu extended family from rural background of Delhi. The informants are patient himself, patient's wife, and patient's son. The nature of information is reliable and adequate. Chief complaints: according to the patient, I do not have any problem. According to family members, muttering and talking to self, suspiciousness and fearfulness since last 5 years. The onset of the complaints is insidious. The course is continuous and fluctuating. Predisposing factor is illness in the father and sister, thereby genetic predisposition. Precipitating factor and perpetuating factor could not be elicited. History of presenting illness. Patient was apparently maintaining well around 5 years back when he started having disturbance in his sleep. One night he fell asleep at 4-5 am in the morning and got up at 7 am and appeared restless the whole day. This continued for few weeks without any specific mood change or alteration of any other biofunction. After few weeks, patient started hearing a male voice speaking to him. It was an unrecognized voice coming from outside the home into his body. He could hear the same voice in full consciousness along with the voices of other family members. However, the voice would be clearer when he was alone. The voice told him things like, "You have to become a good person." He continued to hear this voice the next day as well. This lasted for 5 to 10 minutes each time and occurred around 1 to 2 times per day. Over the next few weeks, it gradually progressed to 20 to 30 times a day. After another week, the patient started telling family members that he was able to hear the voice of Lord Shiva, which was coming from the sky and asking him to become a good person. He would be seen sitting in a squatted position with arms folded and would appear fearful when he was in his shop. When his wife inquired, he told her that he could see Lord Shiva dancing in front of him. As per the patient, the Lord Shiva was about 10 to 15 meters away and around a foot taller than him. During the same time, he could see his family members around him clearly. He could see the same for about 5 to 10 minutes and he continued to see Lord Shiva and hear his voice at the same time. Such happenings initially occurred almost once daily but later became as frequent as 8 to 10 times per day over the next 6 months. In addition to the above, the patient started voicing that his neighbor was jealous of him. Because only he could see God, he added that the neighbor was planning to harm him out of jealousy. His wife found this strange and told him that it was unlikely as they had good relationships with their neighbor. But the patient would not be convinced. He also claimed that a cat that passed inside their house was sent by the neighbor as he had seen the same cat in the neighbor's house earlier the day. He added that the neighbors had sent the cat to find out what the patient was talking about them. Later, over next 1 to 2 years, in addition to the above, the patient started hearing another voice that was different from Lord Shiva's. He started saying that God is talking to him. The voice told him that his son was Manmohan Singh and his daughter was Pratibha Patil. He would share this with his family members, and when family members asked for an explanation, he said that Bhagwanji told him this and he believed this. During the same time, he voiced that he could see the Virat roop of God who wore a garland of flowers and golden ornaments in his ears and neck. He described God as having a fair complexion. As per the patient, God's body was as big as to cover the most of the sky and he trembled in fear, thus sitting in a squatting position in front of him. He stated that God would not always be very clear and would disappear after some time. He could see the same vision even with his eyes closed, and he would become aggressive when family members denied believing him. He also voiced that he could hear voices of 5 to 6 males and 4 to 5 females who would talk with the God. The voices were of unknown people and came from the sky. They were as clear as the voices of the family members. These voices would ask God, referring to the patient, to kill him, and he would hear God replying to those voices that he would kill him by boiling him in oil. The patient seemed fearful for most of the time on most of the days due to this. Symptoms gradually worsened over the next 6 months. He had stopped caring for himself. His biological functions like sleep and appetite were disturbed. He would not sleep at night and did not eat anything until asked to. He seemed restless and his facial expressions felt as if he was fearing something for most of the time. He also stopped working and going out and stayed at home for most of the time on most of the days. Therefore, for the above things, he was brought to the OPD for management. Negative history. There is no history of any thought insertion, withdrawal, broadcast, made impulse, affect, act, somatic passivity, or delusion of control, influence, or passivity. No mutism, echolalia, echopraxia, or verbigeration. No overfamiliarity, decreased need for sleep, or hypersexuality or over grooming. There was no pervasive or persistent sadness, prolonged tiredness, ideas of hopelessness, helplessness, attempts of self harm, delusion of sin, nihilism, or poverty. No repetitive, intrusive thoughts, actions, images, etc. were there. No history of substance use, seizures, head injury, or loss of consciousness was present. The past history is nil significant. In the family history, the patient's father died at the age of 52 years. It was a sudden cardiac death. Patient's father was fifth pass shopkeeper and he suffered from schizophrenia and he was a smoker as well. Patient's mother is 70 years old. She is third pass housewife and shopkeeper currently staying with the patient. Siblings, his first sister, who is the elder sister, is 43-year-old, 10th pass homemaker and healthy. He has a brother who is 40 years old, 10th pass, married, adopted by uncle and healthy. Then there is a second sister who is also elder, is 35 years old, BA pass, homemaker, suffering from schizophrenia. The interpersonal relationships among the family members are cordial. In the second sister, there is a family history of mental illness, which is a continuous illness which is characterized by suspiciousness against her husband, aggressive attitude and disruptive behavior, hearing voices not heard by others, running out and avoiding household chores for the last 8 years. She has been diagnosed with mental illness and currently on treatment but still symptomatic. The history is suggestive of psychosis in the sister. Family's attitude towards illness. Initially, the family members were confused and concerned about the patient's unusual behaviors. Gradually, there is a progression to increased fear, helplessness, and frustration as symptoms became severe and persistent. Eventually, the patient's family sought psychiatric help due to worsening self-care and aggression. Family's understanding of illness, initially it was interpreted that the patient's experiences, like the things he was seeing and he was hearing, were possibly religious or spiritual. Later, the family members developed some kind of medical understanding after the persistence of the symptoms and deterioration in the overall functioning of the patient. Expressed emotions. There were mixed expressed emotions that were observed. In the early phase, the family was supportive but confused attitude, and in the later phase, we see that there is a high emotional over involvement as the family members are confronting the patient, and this has led to the patient being aggressive at times. Personal history, birth history not known, early developmental history not known, education history, he passed 10th grade, left studies to work in the shop. Occupational history, he worked in the shop until 2003, then he was unemployed. Sexual and marital history, the patient married in 2010. It was an arranged marriage with parental consent. The patient's sexual intercourse has been infrequent since the onset of symptoms. Before it was fine. The patient has two children. The first child is 9 years old and he is a student of class 3. Second child is 7-year-old and she is a student of class 1. Present living situation, the patient stays in his own pakka house where overcrowding is present and mild financial constraints are seen in the family members. It is mainly because the patient is not being involved in the course at the shop. Premorbid personality, social relations. A patient had 8 to 10 friends in the locality. He was helpful. He mixed with the relatives and gelled up with the neighbor well. He had few good friends. He was neither aggressive nor submissive. Intellectual activities and hobbies. The patient participated in social gatherings. He took responsibilities, played cards, and was interested in his work. The mood was stable. Character, attitude towards work and responsibility. He preferred to work by himself mostly and he welcomed responsibility. Interpersonal relationships, he was trustworthy for the people, took pride in it, and was cordial. Standards in moral, religious, social, and health matters, it was average. Aspiration to help sisters settle, did not wish for much of comfort and luxuries in life, and his aim was to sustain the family. He preferred home food. Energy was average, fantasy, nothing specific, habits regular, reading newspaper, gossiping, passing time over tea, and tobacco chewing. Impression well adjusted. General physical examination, thin built, conscious and cooperative. Pulse rate was 88 beats per minute, it was regular. Blood pressure was 120 by 80 mm of Hg, it was taken in right arm. Respiratory rate was 14 per minute. The patient was afebrile. The patient's height is 176 centimeter, weight is 60 kgs, and BMI is 19.36 kg per meter square. Waist circumference is 76 centimeters. There is no evidence of any pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Only tooth cavities are present on the general examination. Systemic examination in the cardiovascular S1, S2 heard. It was regular and there are no murmurs which are heard. Respiratory system, bilateral air entry is present and there are no adventitious sounds. Gastrointestinal, it is soft, non-tender, and no hepatosplenomegaly or no other organomegaly was observed. Central nervous system examination, cranial nerve examination, all the cranial nerves from 1st to 12th were within normal limits. The sensory system revealed no abnormality. In the motor, the patient's bulk, tone, power, all are within normal limits. There are the cerebellar signs and the autonomic nervous system are also within normal limit. Mental status examination, general appearance, attitude and behavior. Patient entered the room with his wife. He did not return the greetings of the therapist, but he sat on the offered chair. He appeared untidy and ill-kempt. His hair were messed up. It seemed as he had not shaved for some time, as beard was not managed properly and not even clean. Clothes were dirty with shirt not properly tucked into the pants. Eye-to-eye contact was initiated but not maintained throughout the conversation, and the patient kept scanning around in the room. The rapport could not be established. The patient used abusive language on and off during the interview, and he would be seen smiling and muttering to self intermittently in between during the interview. Psychomotor activity was increased as the patient was seen smiling and muttering to self during the course of interview. The speech is spontaneous, relevant, and coherent. Drain amount and volume was normal. Tonal inflections were present, and his reaction time was average. Affect, subjective, I am fine. Objective affect is irritable. Range was restricted. Reactivity was present. Affect is congruent to thought and to the surrounding. Now, thought, form, and flow. There is no abnormality detected. Content. Doctor, tell me something about your illness. Patient, I do not have any illness. Doctor, what brings you here today? Patient, I have been brought here forcefully. Doctor, why so? Patient, shut up and let me go. I have to sleep in my bed. Doctor, you seem bit stressed out. Can I help you in any way? Patient, it is because of my neighbors. They keep troubling me in one form or another. Doctor, why so? Patient, because God has showered his blessings upon me and talks to me and comes to meet me. And I feel that you are also from their gang and you want to know my secrets. The patient did not elaborate further on this. My impression for the above verbatim is there are ideas of persecution and grandiosity. Perception. Patient. God has showered his blessings upon me and talks to me and comes to meet me. Also, there are many other people with God who keep talking about me the whole day, but I don't talk to them just like I talk to God. Doctor, kindly tell me about this. Patient, no, I don't want to. Doctor, how do you feel when this happens? Patient, I used to feel fearful earlier, but now it's okay. Lately, I don't know why, but God has also started to threaten me. But I am sure I will please him again and he will be happy again. Whenever he comes, he talks to me and I too talk back. I think those other people around him have said negative things about me to the God because since starting they were against me and used to threaten me as well. Doctor, do you hear him clearly? Patient, yes, yes. Why won't I hear him? His voice comes to inside my head and body, and he keeps talking to me the whole day about everything I do. At times, he gets upset with me and starts threatening me, but I know I can please him again anytime. Doctor, is it a male voice always? Patient, yes, mostly it is, but I hear a lot of people chattering in the background who are also trying to talk to me, but I do not talk to them most of the times, as I've already told you. After this, the patient left the interview room and did not answer any questions about the things he used to see. My impression from the above verbatim is third person auditory hallucinations are present. In the higher mental functions, the patient did not cooperate for proverbs and similarities testing. In the judgment, the personal judgment was impaired, social is impaired, and for the test judgment, the patient did not cooperate. Insight. Do you feel you have any symptoms? Patient says, no, these are not symptoms, these are blessings. You won't understand. Doctor, do you feel any of these can be illness? Patient, no, not at all. What are you even saying? So my impression is grade 1 by 6 insight. Diagnostic formulation. The patient is a 40-year male who is 10th pass, unemployed, unmarried, of middle socioeconomic strata, belonging to a Hindu extended family of rural background of Delhi, with family history of similar mental illness in father and sister, where father has passed away and sister is under treatment but still symptomatic, with nil significant past and personal history and well-adjusted pre-morbid personality. He presented with an adequate and reliable information of 5-year illness of insidious onset and continuous course, characterized by muttering and talking to self, suspiciousness and fearfulness, with biosociooccupational dysfunction, with MSc revealing ill-kempt appearance, poor eye-to-eye contact, poor repo, increased psychomotor activity, irritable affect, with ideas of persecution and grandiosity, with third person auditory hallucination, impaired judgment and grade 1 insight. Thus, my diagnosis for the case according to ICD-10 is F20 schizophrenia, and my differential diagnosis includes F29 psychosis NOS, not otherwise specified. The management plan for the patient is locus. I would like to admit the patient in view of increased aggressiveness, deteriorating symptoms, and socio-occupational dysfunction. The focus would be acute symptomatic relief and relapse prevention. Modus. After the admission, the patient symptoms shall be rated on PAN-SS, which is positive and negative symptom scale for schizophrenia. All the routine investigations like complete blood count, liver function test, renal function test, blood sugar levels, lipid profile, and ECG will be done. I would like to offer patient tablet olanzapine 5 mg, which would be slowly up titrated it till the minimum effective dose. I would also like to supplement it with clonazepam 0.5 mg and pantoprazole 40 mg before breakfast. Thereafter, the response will be gauged on PAN-SS scoring, which would be done weekly. Also, I would like to do repeated MSA to establish delusion, visual hallucinations, and for higher mental functions, which could not be established earlier. Non-pharmacological management, I would like to psychoeducate the patient's family members about the illness, the nature of illness, the symptoms, duration, and the treatment options. Also, as the response starts, I would like to work on the insight facilitation of the patient. In the long term, I would like to continue with the pharmacological and non-pharmacological management, the drug on which the patient is stable, with constant monitoring of his metabolic profile and for extrapyramidal side effects. Thank you.